Have you ever tried to describe a really specific physical sensation to a doctor?
Oh, it's incredibly difficult.
Right. Like you walk into a clinic and you're trying to explain this subtle, persistent pain. Or maybe it's a feeling of, I don't know, looseness.
Or that chronic heaviness.
Wait, exactly, that structural heaviness. But as you describe it to them, you realize that you and the doctor are just operating on completely different frequencies.
You're speaking two different languages, really.
Yeah, because you're describing a lived experience, right? And they are looking for a quantifiable metric. You say it feels heavy, and they want like a diagnostic coordinate.
And that is the inherent tension in diagnostic medicine. A patient's somatic reality is profoundly real to them, obviously. But clinical protocols, they're built on measurable, reproducible data.
Right, they need numbers.
Exactly. Historically, if we couldn't put a number on a physical feeling, that feeling risked being marginalized or, well, at the very least, completely mismanaged.
And nowhere is that communication gap wider or honestly more fraught than when we talk about pelvic floor dysfunction. Which brings us to today.
It's a huge topic.
It really is. So for today's custom-tailored deep dive, we are digging into a massive stack of really dense medical studies, clinical trial protocols, and diagnostic textbooks.
And they're all focused on mapping the pelvic floor.
Yes. Our mission for this deep dive is to figure out how exactly 3D pelvic floor ultrasound mapping correlates to real patient sensation. We want to know, can modern medicine literally put a ruler to a feeling?
It's a fascinating question.
Okay, let's unpack this.
Yeah.
Because I think we need some background first.
We do. To understand the magnitude of the shift, we really have to look at the historical baseline.
Right, how they used to do it.
Yeah. For decades, evaluating issues like chronic pelvic pain or vaginal laxity relied on a huge degree of subjectivity.
Like just asking the patient questions.
That and a digital exam. A practitioner would use their fingers to assess muscle tone and attachment. And while that's valuable, it relies heavily on the practitioner's own tactile experience.
There's subjective feeling of your subjective feeling.
Precisely. But the diagnostic imaging technology we're looking at today, specifically 3D and 4D transperineal ultrasound, or TPU,
Right.
and endovaginal ultrasound, EVUS, these have completely changed the paradigm.
Because they can actually see it now.
Yes. Doctors are no longer just feeling around for structural integrity. They're rendering a high-resolution, real-time biomechanical map of the entire region.
Okay, so I want to visualize what that map actually looks like.
Yeah.
Because I think a lot of people, they picture the pelvic floor incorrect.
It's very misunderstood.
Right. It's often described in the basic literature as a hammock, which frankly feels a bit, I don't know, passive.
Yeah, hammock just sits there.
Exactly.
Yeah.
But looking at the biomechanical data in these sources, the levator antemuscle, which is the primary structural support we're talking about, it functions much more like a dynamic load-bearing chassis of a vehicle.
I like that analogy.
Or like a really complex suspension bridge. It's an intricate, multi-layered system carrying the weight of the pelvic organs, but it's constantly adapting to different internal pressures.
That is a much more accurate structural comparison. The levator ante isn't just hanging out. It is under constant active load.
Always working.
Right. And that's why the 3D and 4D ultrasound techniques described in the sources are just so revolutionary. When a doctor uses TPU, they are fundamentally performing a dynamic structural load test.
A stress test for the pelvic floor.
Exactly. And to do it, they position the transducer to achieve a very specific 85-degree acquisition angle.
Wait, why that specific angle? Like, what does 85 degrees give you that 90 or 45 doesn't?
What 85 degrees, the acoustic window captures the entire levator hiatus without the pubic bone getting in the way.
Oh, okay.
Yeah.
And the levator hiatus is?
It's the central anatomical opening in the pelvic floor. It's what allows the urethra, the vagina, and the rectum to pass through.
Got it. So the bone usually blocks the view.
Right. But by using that exact 85-degree angle, the ultrasound can sweep from the pubic symphysis, that anterior bony anchor, all the way back to the anorectal junction.
So they see the whole picture.
The whole thing. They render this complete structural ring. The Gothic arch of the bone, the muscle attachments, all of it in real time.
Wow.
And they aren't just looking at the muscle at rest. They watch this chassis functioning dynamically. They observe it during a contraction, like a Kegel, and crucially for our discussion, during a Valsalva maneuver.
Bearing down, basically.
Yeah, exactly.
Watching a real-time structural stress test is incredible.
Yeah.
Like, from a diagnostic perspective, it's amazing. But I do want to push back on the core premise of our mission for a second here.
Okay, go ahead.
It is undeniably a marvel that we can render this beautiful 3D image of a muscle under load. But if you are the patient and you tell a doctor, I feel an intense localized heaviness, how does a visual rendering of a muscle stretching actually validate the feeling?
You mean, how do we know the image matches the sensation?
Yeah, a wide opening is just a wide opening on a screen, right? How does the data bridge that gap?
This raises an important question, and it's the exact hurdle these clinical studies aim to clear.
Oh, so they address this.
They did. They do it by measuring something called ballooning, or hyperdistensibility.
Ballooning. That sounds uncomfortable.
It's a very descriptive clinical term. The ultrasound software calculates the exact area of the levator hiatus in square centimeters, and the data establishes a highly definitive clinical cutoff.
Which is?
An area of 25 square centimeters or more during a Valsalva.
The 25.
Yeah.
So 25 square centimeters is the threshold where the structure basically fails its load-bearing capacity.
Precisely. If that opening stretches to or beyond that 25 square centimeter mark, the mathematics align almost perfectly with the patient's physical sensation of prolapse.
Because things are literally dropping.
Right. Gravity is overcoming the muscular resistance, the organs are descending, and they're pulling on the surrounding fascial tissue.
And that tissue has nerves in it.
Exactly. It's lined with stretch receptors. When those receptors are fired by that specific degree of structural ballooning, the signal sent to the brain translates into that conscious sensation of heaviness or dragging.
So the ultrasound confirms that the physical stretch has reached the exact mathematical threshold required to trigger that neural response.
You hit the nail on the head.
That is wild. The subjective feeling is literally just the brain's translation of a 25 square centimeter biomechanical failure.
It puts a ruler to the feeling, just like you said.
Yeah, you are seeing the mathematical coordinate of a feeling. And that mechanism structural failure triggering sensory experience, that perfectly sets up the data in these sources regarding vaginal laxity.
Oh, absolutely. Vaginal laxity is one of the most chronically underreported somatic complaints in women's health.
It really is.
In clinical questionnaires, patients frequently describe it as a sensation of excessive flaccidity or just a feeling of a wide vagina.
And the prevalent stats in the literature are staggering. The data indicates that vaginal laxity affects between 24% and 38% of women.
It's a massive demographic.
But the number that jumped out at me the most was that 83% of women fail to ever discuss this sensation with a healthcare professional.
Which is heartbreaking.
83%. We're looking at a huge population experiencing a tangible structural change, but they just choose to remain silent.
The texts suggest this stems from a mix of embarrassment or just this pervasive assumption that structural degradation is an unavoidable consequence of childbirth.
Like, well, I had a baby, so I guess this is just my life now.
Exactly. And historically, because the sensation was difficult to quantify without advanced imaging, some practitioners kind of lean toward dismissing it.
Or saying it's in their head.
Right, categorizing it as psychogenic rather than a real physical somatic issue.
But the 3D EVUS data completely dismantles that, doesn't it?
It completely throws it out the window.
Yeah.
Researchers developed a metric called the levator any deficiency score, or the LAD score.
Okay, what did that do?
They used the endovaginal ultrasound to systematically divide the levator ani into specific compartments, and then they score each section based on its anatomical thickness and how well it's attached to the pubic bone.
So they're basically mapping out the microscopic thinning and detachment points across the whole chassis to create a composite score of structural failure.
Yes. And the correlation to the patient's lived experience is undeniable here.
What do they find?
The studies demonstrate that a high LAD score, meaning significant muscle deficiency, is strongly associated with the reported sensation of vaginal laxity 1 year postpartum.
Wow, 1 year out.
The mathematical correlation is massive. The odds ratios are incredible. Furthermore, when they utilized transvaginal ultrasound to measure the thickness of the proximal vaginal wall,
Which is another measurement entirely.
right, the physical thinning, measured in exact millimeters, directly tracks with clinical vaginal laxity questionnaire scores.
So the thinner the wall, the worse the score.
Exactly. There's actually a p-value of 0.025, which in statistics means it is incredibly precise and significant.
Here's where it gets really interesting. I want to make sure the weight of this data isn't lost on anyone listening. Because the researchers didn't just find a vague pattern, right?
No, it's highly specific.
The ultrasound data is so precise that doctors can now draw a straight, mathematically undeniable line between the exact millimeter of wall thinning and the exact severity of looseness the patient reports on a diagnostic survey.
It validates everything they are feeling.
Right. The imaging proves definitively that the patient is not imagining things. The physical thinning of the tissue maps flawlessly to their internal sensation.
It transforms a subjective vulnerability into a totally objective diagnosis. And validation is often the first therapeutic step.
It really is. Okay, so if laxity is the suspension system giving out the structural failure of a muscle overstretching, what does the ultrasound show when the system is pulled entirely too tight?
Ah, the other end of the spectrum.
Because the source material makes a hard pivot from excessive looseness to hypertonia and chronic pelvic pain.
What's fascinating here is the structural visualization of pain. Let's look at the data on patients diagnosed with deep infiltrating endometriosis, or DIE.
Okay.
These are individuals who frequently report severe chronic pelvic pain and superficial dyspareunia, painful intercourse.
Right, highly painful.
When practitioners use 3D transperineal ultrasound on this group, the structural map looks entirely different. Instead of ballooning or thinning, the imaging reveals hypertonia.
So the muscle is too tight.
Exactly. It's essentially frozen in a state of high-tension guarding.
The chassis is locked up, like it's bearing too much load, even when it's supposed to be resting.
You've got it. The resting state ultrasound captures a significantly smaller levator hiatal area compared to asymptomatic patients.
The opening is physically smaller.
Yes. But the crucial diagnostic marker appears during the dynamic phase. When the patient is asked to perform a Valsalva, to bear down, the muscle demonstrates an absolute inability to relax or distend.
It just refuses to yield.
Right. The entire opening remains rigid. Endometriosis is a systemic inflammatory condition, right? So the pelvic floor musculature reacts to that chronic inflammatory pain by entering a continuous defensive spasm.
That makes so much sense. The muscles are exhausted from constantly bracing against the pain, which, ironically, generates a secondary layer of structural pain.
Exactly. The tightness is a neurological defense mechanism that becomes its own problem.
But, I mean, knowing the muscle is locked up is only half the battle. How are they using this visual data to actually intervene and unlock the tissue?
Well, the standard intervention here is specialized pelvic floor physiotherapy. The whole goal is down-regulating that hypertonic response.
Just getting it to relax.
Right. And the ultrasound provides the clinical proof that it works. Following sustained physiotherapy, follow-up TPU scans actually show a measurable increase in the hiatal area at rest.
So the muscles physically lengthen.
The muscle fibers are physically elongating. And that directly correlates with the patient's self-reported drop in chronic pelvic pain.
That brings up a methodology in the sources that absolutely blew my mind.
The visual feedback.
Yes. They aren't just using the ultrasound to check progress after the fact, like at a checkup. They are actively using the TPU to provide visual biofeedback during the physiotherapy session.
The real-time application of this is just brilliant.
It fundamentally changes the neuromotor loop. Like, when a muscle has been locked in a state of hypertonic guarding for years, the brain essentially forgets how to send the relax signal.
There's a profound proprioceptive block.
Right. But by having the patient look at the ultrasound monitor while trying to relax the pelvic floor, that visual feedback bypasses the internal block.
They can literally watch their own muscle fibers elongate on the screen.
It's amazing. It reinforces the brain-body connection. They feel the subtle internal shift, and their eyes confirm the structural relaxation in real time. The diagnostic map literally becomes part of the cure.
It creates a really powerful closed-loop system of neurological reinforcement. But we do need to look at the primary catalyst driving these extreme structural changes in the first place.
Yeah, what's causing all this?
Well, whether we're talking about the hyperdistensibility of laxity or the compensatory tightness of chronic pain, the source material points to one overriding biomechanical event.
Childbirth.
Yes, the extreme tensile strain of a vaginal delivery.
The mechanical forces exerted on the levator ani during childbirth are just staggering. To accommodate a newborn, that muscle complex has to undergo macroscopic stretching that honestly borders on the limits of human tissue tolerance.
It's an immense load.
And sometimes the tissue simply exceeds those limits. If the pelvic floor is a hammock, this is what happens when one of the ropes snaps.
The clinical term for the structural failure is a levator ani avulsion. Yeah. And this isn't just a stretching or a thinning. This is a macroscopic mechanical trauma where the muscle forcefully tears away from its insertion point on the pubic bone.
It's complete detachment of the chassis from its anchor.
Yes. And the sources indicate this happens in roughly 13 to 36% of women during their first vaginal delivery.
Up to 36%. That is wild. Obviously, the localized pain of the initial tear is one thing, but how does an avulsion actually feel for the patient months or years later?
If we connect this to the bigger picture, patients frequently present with symptoms of pelvic organ prolapse. They describe a distinct lump or a really profound dragging sensation in the vagina.
Okay, so how do we structurally map that dragging sensation?
Practitioners use a sophisticated software rendering called tomographic ultrasound imaging, or TUI.
TUI.
Right. TUI processes the 3D volume data and generates 8 specific sequential slices of the levator complex moving from the pubic bone upwards.
The sources compared it to a sliced loaf of bread, right?
Yes, that's the perfect analogy. It's like analyzing a structural load test layer by layer. It allows the diagnostician to pinpoint the exact millimeter where the muscle fibers ripped from the bone.
But the avulsion itself is just the severed anchor. The dragging sensation the patient feels comes from what happens next, right? The structural collapse.
Exactly. Without that muscular anchor, the pelvic organs are subjected to the relentless downward pull of gravity. And the imaging data provides incredibly precise cutoffs for when this collapse triggers the symptomatic feeling.
And what are the numbers?
If the TPU reveals the bladder descending 10 millimeters below the pubic bone,
10 millimeters.
or the rectum descending 15 millimeters, it correlates perfectly with the clinical presentation of prolapse.
So the gravity-induced descent pulls on the fascia, and that tissue is loaded with those stretch receptors we talked about earlier.
Yep, the same mechanism.
When the bladder drops exactly 10 millimeters, it exerts just enough tensile strain on those receptors to fire the neurological signal that the brain interprets as a heavy internal drag.
It's an unbroken chain of cause and effect.
The ultrasound is mapping the precise millimeter of structural descent required to generate the sensation. That is incredible.
The biomechanical cascade is perfectly visualized.
Which naturally forces the conversation toward intervention.
Right, how do we fix it?
Yeah. We have this profound ability to map the exact nature of the structural failure. A tear, a thinning, a hyperdistension. How are clinical researchers actually attempting to repair this architecture, and how does the imaging track the healing?
The clinical trial protocols in our stack provide a really good window into the vanguard of treatment here. They are aggressively studying the efficacy of radiofrequency or RF treatment.
Right, as an alternative to just basic pelvic floor muscle training.
Yep.
Or like invasive surgery.
Exactly.
I read the technical specs on the RF intervention, and I have to admit, it sounds intensely aggressive.
It does sound a bit sci-fi.
They are using an electroarray equipped with 64 microneedles to deliver up to 45 watts of thermal energy directly into the vaginal tissue.
That's the protocol.
My immediate reaction to that was, wait, won't 45 watts of heat inherently burn or scar the lining? Like, how is that regenerative?
That is a very critical distinction to make. The energy delivery is what they call fractionated.
Fractionated, meaning it's broken up.
Exactly. The device doesn't emit a continuous blast of heat. It pulses the thermal energy in microscopic fractions of a second.
Okay, so it doesn't overheat.
Right. This fractionated pacing allows the surrounding superficial tissue to cool almost instantly, which prevents burns or ablative scarring. The microneedles bypass the surface to deliver that thermal shock deeply into the submucosal layers.
So the goal isn't to, like, surgically scar the tissue into shrinking.
Far from it. The goal is controlled microtrauma.
Okay.
The combination of the mechanical needle penetration and the deep thermal pulse triggers a massive cellular healing cascade.
And what does that do?
Specifically, it stimulates neocollagenesis and neoelastogenesis.
New collagen and new elastin.
Yes. The localized heat forces the body's fibroblasts to metabolize and lay down entirely new, structurally dense collagen and elastin scaffolding inside the tissue.
Wow. You are literally tricking the body into rebuilding its own suspension cables from the cellular level up.
That's exactly what's happening.
But if you are stimulating invisible microscopic collagen scaffolding, how do the researchers actually prove the structure is stronger? Like, how do you measure neocollagenesis without a biopsy?
They utilize the exact same diagnostic mapping.
The ultrasound.
Yes. The trial protocols use pelvic floor muscle morphometry via ultrasound to physically map the tissue thickness before and after the RF intervention.
Oh, so they can see it get thicker.
They physically measure the proximal, middle, and distal thirds of the vaginal wall. They are looking for objective millimeter-scale increases in tissue density resulting from that new collagen.
And then they match that to how the patient feels.
Crucially, yes, they correlate that mapped physical thickening directly to the patient's subjective experience using the Global Response Assessment and the Female Sexual Function Index.
So they're continuously verifying the new structural map against the patient's lived reality.
Exactly.
And while morphometry measures thickness, there's another diagnostic technology mentioned in these texts that measures something entirely different. And it honestly feels like the ultimate validation tool.
You're talking about vaginal tactile imaging.
Elastography.
Elastography is a monumental leap in quantifying biomechanics. As we discussed earlier, the historical standard was a digital exam, right? Relying on the doctor's subjective sense of tissue resistance.
Just pushing and feeling how tight it is.
Right. Well, vaginal tactile imaging digitizes and quantifies that exact mechanical resistance. It uses a highly specialized probe that's embedded with hundreds of microscopic pressure sensors.
It's essentially a high-resolution array of tactile feedback monitors.
Exactly. As the probe interacts with the vaginal walls, those sensors map the precise biomechanical elasticity of the tissue.
So it's mapping the stretchiness.
It measures the tension gradients, the relative stiffness, or the distensibility of the mucosal and muscular layers. It literally takes the subjective concept of tissue tone and translates it into a high-fidelity quantitative pressure map.
So if a patient complains of a localized, painful rigidity, like we saw with the endometriosis hypertonia, or maybe the distressing lack of resistance associated with laxity, the tactile imaging literally creates a digital map of that exact physical tension.
Yes, it doesn't just show the structure, it maps the physical rigidity of the tissue itself.
That is the absolute pinnacle of validating a physical sensation.
It completely eradicates the ambiguity. It translates subjective sensory input into objective biomechanical data.
So what does this all mean? If you are listening to this and you have ever struggled to convey the reality of a physical sensation to a medical professional, the data we've explored today is a testament to the fact that your somatic experience is valid.
It is entirely real.
It is measurable, and it is deeply rooted in biomechanical reality. Advanced 3D pelvic floor mapping, elastography, high-resolution ultrasound, these prove that what you feel is not just an abstract concept.
Or in your head.
Exactly. Whether it is the dragging, heavy descent triggered by an avulsion, or the painful, neurologically locked-up hypertonia of endometriosis, or the excessive looseness of vaginal laxity, these subjective sensations have highly precise, observable, and treatable physical coordinates. Medicine has finally built the tools to map the internal terrain of your lived experience.
The era of diagnostic ambiguity in women's pelvic health is rapidly closing. But, analyzing this stack of literature, I am struck by a really compelling implication for the future.
Oh, what's that?
Well, throughout our discussion, we have observed how practitioners use ultrasound to meticulously map structural failure after the trauma has occurred.
Right, tracking the damage from childbirth.
We use the imaging to explain why a patient is currently suffering, but consider the preventative potential here. What if, in the near future, comprehensive 3D pelvic floor mapping became the standard of care before a patient ever goes into labor?
Oh, wow.
If we possess the technology to map the precise biomechanical tolerances of a woman's levator complex, we could theoretically predict her individual structural risk for severe avulsions or irreversible laxity.
So you would know ahead of time if the muscle was going to snap.
Exactly. By shifting the diagnostic timeline, doctors could proactively tailor the method of delivery. They could actively prevent the structural trauma before the patient is ever forced to endure the sensation of it.
Using a predictive structural map to just outmaneuver the trauma entirely, that is a fundamentally paradigm-shifting approach to maternal medicine.
Wow.
Well, thank you for taking this deep dive with us today. We hope unpacking this diagnostic evolution empowers you to trust the signals your body is sending and encourages you to keep exploring the intricate, deeply fascinating architecture of your own biology. The tools to measure the unseen are getting sharper every day, proving that your map is real and your physical experience is entirely valid.